Hello, and welcome to the Clinical Liver Diseases video series. Clinical Liver Disease is an official digital learning publication of the AASLD. My name is Karim, a first-year gastroenterology fellow at NYP Brooklyn Methodist Hospital, and I'm the author of Immunosuppression Management of Refractory Checkpoint Inhibitor-Related Hepatotoxicity. Immune checkpoint inhibitors, or ICIs, have noticeably transformed the approach to cancer therapy of inoperable, locally advanced, or metastatic cancers of many types, offering a novel and excellent therapeutic option for many cancers, but the development of several immune-related adverse effects has really affected several organs, limiting the prolonged use of ICIs. One of the side effects is called ICI-related hepatotoxicity, and it's a frequently encountered ICI-related adverse event. The common terminology criteria for adverse events has suggested a template for assessing the degree of liver injury and graded it from 1 to 4. These are really criteria based on the degree of elevation of enzymes and bilirubins. Though the incidence of immune checkpoint inhibitor related hepatotoxicity is variable, it is reported to be between 1 to 30%. And grade 3 or 4 or severe immune-related hepatotoxicity has been reported up to 20% of cases. And it's divided into 3 modes. It can present as a cholestatic, hepatocellular, or a mixed hepatocellular and cholestatic hepatic liver injury. Though it is typically asymptomatic and detected incidentally on routine testing during ICI treatment, it does present about 8 to 12 weeks after treatment has commenced, but there are some case reports that have reported this incidence to be up as 2 weeks after therapy has begun. While the management of IRH really depends on the grade of disease, there are currently no general consensual guidelines. They're mostly expert-based recommendations. The grading of liver injury, grades 1 to 4, offers really suggestions and recommendations to what to do with the medications after it's been diagnosed. Generally, with grade 1 injury, ICIs can be safely continued with close monitoring of liver enzymes every week. Grade 2 does recommend withholding therapy and starting a small dose of prednisone up to 1 milligram per kilogram per day and monitoring liver chemistries up to twice weekly. For grade 3, it is recommended to withhold ICI therapy temporarily and start methylprednisolone 1 to 2 milligrams per kilogram or the equivalent while monitoring liver chemistries every other day. For grade 4, it has been recommended to permanently discontinue ICI therapy and consider hospitalization in these patients with IV steroids and monitoring of liver chemistries every day. There have been cases of IRH recurrence, really noted as a rebound alanine aminotransferase, and that's been reported to occur during steroid reduction and post-treatment with methylprednisolone. Has been successful really in the treatment of steroid refractory IRH with no recurrence after ICI withdrawal. It may suggest that pulse therapy with steroids may be necessary prior to diagnosing steroid refractory IRH. For patients with steroid refractory IRH or those who relapse during drug withdrawal, a variety of immunosuppressants have been suggested on alternative. Based on most society guidelines, MMF and anti-thymocyte-globulin, tacrolimus, tocilizumab, and cyclosporin have all been suggested as treatment options for corticosteroid refractory high-grade IRH. However, there really is no broad consensus for treatment recommendations in this category of patients. Some have recommended that plasma exchange and dual molecule plasma absorption systems for mixed and cholestatic IRH have been tried with some success. Lastly, liver biopsy may aid in early diagnosis or exclusion of steroid refractory immune checkpoint inhibitor toxicity. And it's important to also obtain screening for hepatitis C, hepatitis B prior to initiation of immunosuppression and consider prophylactic antiviral therapy in addition to a broad infectious workup prior to diagnosing. And so on behalf of the clinical liver disease team, I hope that you found this short video very useful. For more information about immunosuppression management for refractory checkpoint inhibitor-related hepatotoxicity, please visit us at www.clinicalliverdiseaselearning.com. Thank you for watching.